Good morning, everybody, and we welcome again to our ninth annual Neuro Symposium. My name is Adil Popolze. For those of you who do not know me, I'm the medical director of the stroke program, and generally I start the meetings off and kind of give an update on how things are going with our program as a whole, and where we are, and hopefully where we're headed. So again, welcome. This will be our schedule of speakers. So this first picture here is just a map of Southern California, specifically LA County. And what you may notice, I don't have a laser pointer, unfortunately, but if you look all the way to the right, you'll see Pomona Valley is on the east end of LA County. In LA County, as of June 2024, there's 52 total stroke centers. 25 are designated as comprehensive stroke centers as level 1 or level 2, and 27 are primary stroke centers. So we're proud to say that here at Pomona Valley, we are a comprehensive stroke center level 1. Level 2 comprehensive stroke centers are thrombectomy capable centers. But again, over here, we are a level 1 and we do everything for our stroke patients. But again, the picture here is what I want you guys to focus on is we're on the far east end and we serve a pretty wide geographic distribution. And once beyond that border that's cut off, we have all of San Bernardino County that we also serve as well. So we have a unique location where we serve both LA County and San Bernardino County. This is a slide that kind of shows specifically LA County and final clinical stroke diagnosis of all LA County EMS transport to Pomona. And what I wanted to highlight here is that we are one of the busiest stroke centers in LA County. And this says there was 273 final stroke diagnoses based on all of the LA County EMS transport. Big picture here is that we're very busy, and this represents only the distribution of patients that we get from LA County and not what we're getting from San Bernardino County and transfers. So with that being said, we get a lot of patients and we see a lot of stroke here at Pomona Valley. Anyways, back to this slide. This is a lot of data here, but this is the volume of stroke transports that come to our hospital. And again, if you look in the bottom right, there's a circle that's around 705. That's where we are. We, again, get a lot of stroke volume transport from LA County EMS. And basically, the last two slides kind of just indicate how busy we are as a stroke center and the amount of volume that we see. So, you know, when we think about where we are in the geographic distribution of LA County, and when we look at ourselves as a whole, I mean, I know we're sometimes just considered a community hospital, but we really are a regional medical center that serves a wide base of patients, both LA and San Bernardino County. And I think the numbers are we serve a patient population of around 1 million lives. So for those of you that obviously work here or help out with the stroke program, we're really proud of what we do here, and we see quite a bit. This slide here looks at basically our stroke volumes throughout the years from the onset of our stroke program back in 2010. You know, again, we're a large volume stroke center. We see a lot of stroke, a combination of hemorrhagic, ischemic strokes. And basically, you know, we're the past couple of years we've been hovering around the mid 800 range of all stroke volume, and we'll probably get to that point this year as well. So again, big picture here is that there's a significant need in the area, obviously, with the amount of strokes that we see, and we do take a lot of pride and importance in what we do here. So this just shows, again, how many we see. This is an interesting slide because the way it works here at Pomona Valley, we activate what's called a stroke alert when we get EMS transport or patients from outside, and we identify them as level 1, level 2 stroke alerts. And that kind of signifies that there is an acute stroke coming in that warrants immediate emergent attention and evaluation for potential thrombolytic or even endovascular treatment. What we're seeing though over the years from 2021, as you can see, is that our stroke alert activations has gone up significantly. And if you look at this year alone, just through 3 quarters, we're at already 1745 stroke alert activations, and we've already exceeded the total amount of 2023. So we are activating a lot. One of the goals that I personally have for this year is to kind of see what we could do to improve the stroke alert activation process. Back in 2021, 44% of our stroke alert activations ended up being stroke diagnoses of acute ischemic stroke, intracerebral hemorrhage, TIA, or subarachnoid hemorrhage. Those numbers are dwindling a little bit, but we're also activating many, many more stroke alerts. Obviously, there's a lot of mimics that come in, and sometimes it's hard to identify these patients. Our biggest non-stroke diagnoses for stroke alerts are dizziness, syncope, vertigo, sepsis, encephalopathy that sometimes do and can present with acute neurological changes, and therefore they get activated as stroke alerts, but unfortunately they end up being something else. So again, our ER is very busy with quite a bit, but obviously as a stroke center, comprehensive stroke center, with the amount of stroke alerts we see, we're very busy. So one of the goals I have this year is specifically to see what we could do to kind of help improve and do better at activating appropriate stroke alerts. This slide shows thrombolytic treatments over the years from 2021 to present. And by thrombolytics, we mean blood thinning medications. And now, since 2021, we've been using tenecteplase. And since the use and onset of that, I mean, we've been flying. We've been doing really a lot more, I think, overall treatments. So what we see even through 3 quarters is that 20.3% of what we've brought in as our stroke alerts have been treated, and the general benchmark for comprehensive stroke centers is 16%. And then that's in terms of IV thrombolytics, and then all thrombolysis treatments, and that is indicative of potentially intra-arterial thrombolytics during endovascular treatments, is 30.9%. So we're doing a really good job of identifying these patients early on to see if they're appropriate candidates and treating them. So again, we're very busy, and we're treating a lot of these strokes, and that obviously leads to better outcomes for our patients. This slide shows just where we are in terms of administration of tenecteplase. And there's always been, in the past years, the golden hour of treating patients and stroke patients with thrombolytics. But really, you want to treat patients as soon as possible. And it does take quite a bit of a process to identify appropriate candidates, because we want to exclude any kind of contraindications to thrombolytic treatments. But the goal has always been to try to improve treatment times. And this slide just shows that we've done a really good job of triaging these patients, getting them to CT, identifying them as appropriate candidates, excluding contraindications. And we're treating patients much faster over the past few years with these implementations that we've made in identifying and activating stroke alerts. So 100% of our patients that come in that are identified as thrombolytic patients are getting T and K within 60 minutes. But our goal has always been to get thrombolytics in as soon as possible. And over the years, we've done a lot to kind of improve times. And this slide just shows that we've really done that, because 93.5% of our patients get thrombolytics within 45 minutes, and 77.2% get less than 30 minutes. And those are really amazing numbers, because, again, at the end of the day, numbers do matter, but what really matters is the faster you treat patients, the better they do. And that's important here. And so we're really doing a good job of identifying these patients and getting treatments going. This shows just our median arrival to IV thrombolytic time. Here at Pomona Valley, our median time is 32 minutes. And this is through 2020. This is for Q3 2024. And this slide kind of shows you from 2021 to where we are 2024. We're kind of making this overall improvement of median times. And Joint Commission CSC median standards are 34 minutes. So we're doing a really good job. Door to puncture. This is for endovascular treatments. Over the years, it's been a big move to try to help improve these times, because there's been delays and sometimes issues with even resources. But we've really made a lot of changes over the past year to try to improve this process. And this slide really shows that we've done that and improved. So right now, our door to puncture time is 79 minutes. Our goal is less than 75. The red line below is what the comprehensive stroke centers are kind of the metric for where most of them are. We want to get there, but this also highlights how we've gone from higher times to lower times, and we're I think can achieve that hopefully within the next 6 months to a year. I think we're really going to get to where we need to get. This is door to device, and again, this is also a highlight of just making changes of getting patients to the IR suite as soon as we can, and trying to remove any barriers that impede the process of it. Our numbers have gotten a lot better over the years, and this is just a highlight and testament to the work that we put in to improve times. This is the stuff that we've done to improve these times overall. Number one, we've started to designate, obviously, and try to identify large vessel occlusions from outside, and by activating level one, level two race stroke alerts. We've implemented multimodality imaging, CT, CT angiogram, CT perfusion to obviously identify good candidates for treatments. And we've addressed CT perfusion processing times by reducing overall time of getting the CT perfusions out so we can interpret them as soon as possible. The biggest change that I've seen really is really getting transport from CT to IR holding. Um, it really does take quite a process to do this. There's a lot of moving pieces, a lot of resources, and we've tried to identify what areas where we were slow at and try to really make changes there. And by implementing these changes, we've really helped to improve our times in getting a rendezvous time from CT to IR, using both ER staff and IR staff to help kind of prep the patients. It's really made a huge difference, and I think we're going to continue to move in that direction. So, overall, we're very proud of where we've come over the years and where we're going. I think we made a lot of progress in terms of overall times, and it's really a testament to all the teams. So I'd like to specifically shout out all our teams in the ER and IR who've really made big strides to help improve these areas.